So, you guys, what we're really going to be talking about tonight is how we move BlephX into a preventative role, because that is very important. So, eye care finds itself in an enviable position with respect to its ability to prevent, arrest, and reverse much of the burden of lid disease. However, it is clear that the infrastructure within primary care must be changed in practitioners and their teams appropriately supported to deliver this paradigm shift from a reactive to a preventative medical model. Now, I wish that I could say that I am a smart enough man where I created this verbiage myself, but what I took is this from a dental model initiative, and I just flipped out a couple words, and it makes perfect sense. And as we go through all of this, everything will correlate heavily to the dentistry model because it is done so well. So there is another lecture out there called Dry Eye Decoded, and actually another one on top of that called Walking the Patient to Yes, Acceptance and Closure. Both of these are not required prerequisites, but they certainly help with the explanation to patients. This is going to be a quick crash course in the biology aspect of it. If anyone is interested in those lectures, you can find them on our YouTube at the Dry Eye channel, or you can reach out to me at Chris, C-H-R-I-S, at Blephx, BLEPHEX.com. But just a quick reiteration, blepharitis simply means lid inflammation and is a precursor to dry eye disease. All patients with dry eye have blepharitis, especially when we rethink of the simple terminology of lid inflammation. Inflammation begins with a bacterial productive structure called a biofilm that produces virulence factors after a process called quorum sensing gene activation. And another word that I like to use for biofilm that is more widely accepted by patients is plaque. So if you're not using the word biofilm or plaque for a patient, we are underserving and educating them on the disease process. Dry eye and blepharitis syndrome is a staged disease process. It is not separate. So starting with folliculitis, which is a biofilm or plaque accumulation, can manifest with lash follicle edema, lash loss, and or misdirection. Second stage is meibomitis, meibomian gland involvement, from minor obstruction to complete blockage, glands that are blocked by meibofilm accumulation and capping. Last stage is lacrimomitis, auxiliary lacrimal gland involvement, always presents after meibomian gland involvement, also called aqueous deficiency. So that's a quick crash course in Dry Eye Decoded, and we'll move on from there. Oh lordy, blepharitis is blepharitis is inflammation of the lids in which they become red, irritated, and itchy, and dandruff-like scales form on the eyelashes. It is a common eye disorder caused by either bacteria or a skin condition such as dandruff or the scalp rosacea. It affects people of all ages. Well, if you remember from Dry Eye Decoded, we need to reevaluate the way that we look at blepharitis. Blepharitis is simply lid inflammation at any stage, from simple lash follicle edema to meibomian gland involvement, atrophy, all the way to lacrimal gland involvement. Some statistics for you. Eyelid inflammation is very common. In a recent survey of American ophthalmologists and optometrists, these eye doctors reported that 37% and 47% of their patients, respectively, have had blepharitis symptoms at some point. Estimated 4.88 million Americans age 50 and older have dry eye. These numbers are using antiquated and outdated definitions and terminology. You can expect these numbers to easily double with the proper definitions, okay? And the estimated almost 5 million Americans with dry eye, obviously we're seeing it in younger than 50. So those numbers will go up as well. In terms of your patient population, when we look at any sign of lid inflammation, especially lash edema or lash follicle edema, we're looking at 80 to 90%. And the 10% that we're not is the 10% of the population that doesn't have a fully developed biofilm yet, which is our younger patient population. Translating science into practice. This is the easy part. We know that the science supports biofilm etiology of chronic inflammation, and that chronic inflammation slowly destroys our tear glands. The answer is simple. Remove the biofilm or plaque accumulation. It's amazing how many times in life just simply cleaning can fix a problem. Dry eye is no different. We need to just clean up these lid margins. The road to dry eye treatment, and this is from my experience going around what I've commonly seen. When I go into an office and I look at their dry eye protocol, we run into it and we say, let's try some at-home solutions, whether it's tears, masks, or lid scrubs. And if our signs and symptoms continue to progress and worsen, we try something in office. Okay, let's try something a little bit more invasive. Let's try something in office. And if our signs and symptoms don't improve from there, well, then we try something a bit more involved. And I'll tell you what's wrong with this hierarchy. We know that tears and lid scrubs are not going to stop the progression of the biofilm, especially on the posterior margin. It's just simply not designed to do that. Band-aids are quite literally a solution, or I'm sorry, not a solution, a Band-aid, and lid scrubs are only going to clean the external anterior segment of the lid margin. When we allow a patient to go home on just tears and scrubs, we are allowing their disease process to progress and get worse. And then, we try something like Blepharitis, but by the time we're at Blepharitis, we already have meibomian gland involvement. So this is my proposal on how we need to look at this hierarchy. Any stage one, and this is going to be our preventative care. This is our edema at the lash follicle. This is what we traditionally call anterior blepharitis. If they don't have any meibomian gland involvement, we need to do something like Blepharitis, like a dental cleaning, and perhaps send them home on Bruder mask or lid scrubs, something that will reinforce and remind them of compliance. Now, if they have any form of meibomian gland involvement, whether you're offering LipiFlow or iLux or tear care, any of the other things out there, Blepharitis needs to be done with it each and every time. It's not a matter of which one should I do, it's both. The disease product, the meibofilm, needs to be evacuated from the meibomian glands, and the surface biofilm needs to be removed from the lid margin itself. I was just speaking with a patient the other day, and she got LipiFlow without Blepharitis, and she said, her signs and symptoms came right back, and I explained to her that she still had her surface biofilm intact, and that led to the reclogging of the meibomian glands. And she actually, I believe, Dr. Watson was one of your patients, and she didn't get LipiFlow with you, so don't let me put you on the spot there. She, in turn, went to Dr. Watson and got IPL and Blepharitis, and she was much, much happier. She's traveling quite a ways to go see Dr. Watson. So with her previous office, she felt incomplete because she didn't get that surface biofilm removed. So definitely hats off to Dr. Watson in North Carolina for giving that patient the complete story, the complete picture. We need to evacuate the disease product from the meibomian glands and also remove the surface biofilm. I want to give you guys some parallels to the dentistry model. Like I said, we're going to rely heavily on this with the patient education and explanation. So in both models, we begin with a plaque or a biofilm. Once again, these words are interchangeable. If we allow this plaque to exist for a long period of time, it will manifest into an itis, an inflammatory disease of the tissue structure. If we allow this itis to exist for a long period of time, well, we are going to turn into a gum disease or a dry eye disease. And if we allow that disease to exist over a long period of time, what's going to happen? Well, our teeth fall out or our tear glands and our lashes fall out. So essentially, we are talking about the same medical and biological process. Let's talk about some of the differences here. And I know that you guys can't answer me, so just kind of answer in your head. Who taught you guys about good oral hygiene? And if you guys said, the dentist, you're missing the stage where it was definitely your parents that enforced good oral hygiene. Well, in terms of good lid hygiene, usually it is the eye care provider that steps in and educates a patient, and usually it's much later in life. When is the first time you as a patient heard the word gingivitis? Once again, if you're saying the dentist or later in life, you're completely forgetting about marketing. You know, earlier in life, we hear the word gingivitis and we attribute it with all the marketing that's out there. We personify it, we villainize it. It has this negative connotation that we know at an early age. Well, patients don't hear the word blepharitis usually until after they're diagnosed. And if we go back to dry eye decoded, we know that we are diagnosing way too late. Ooh, I'm sorry, you guys. It's really hard to do this presentation when I don't have the feedback from the room. We know that we're diagnosing too late. Are patients compliant with at-home care? My patients don't do their lid scrubs. You know, hear that all the time. Well, we definitely brush our teeth, you know, 2 to 3 times a day. So notoriously not in terms of at-home care with lid scrubs and ocular model and the oral model. We are overly compliant. Are patients compliant with in-office cleanings? Well, we go to the dentist once or twice a year to get this this deep cleaning. And in terms of eye care, it's relatively unheard of, and we need to change that. That's the preventative model. Why? We have to ask ourselves, why are we night and day in terms of these two models that are so similar in the process? Well, education is everything. Right now, your dry eye and blepharitis syndrome patients are blindsided. They are blindsided with a diagnosis that they don't understand. They're coming in with eyes that are constantly watering, and you're informing them that they have dry eye disease. And you have to, you know, look at the patient. The thing about it is you've got 3 components to your tear film. You have the lipid layer, the mucus layer, and the water layer, and you're deficient more than likely with your complaints in the lipid layer. Okay, doc, whatever. I mean, I can't wrap my head around this diagnosis of dry eyes when they're watering, but how much is this going to cost me? They're blindsided with costs that they were not financially prepared for. Why doesn't insurance cover this? Well, let me emphasize on some more of the education aspect. Educating and raising awareness early leads to earlier acceptance. By looking at the true definition of blepharitis, who benefits from BlephX? Essentially, it's everyone. Can't realistically expect every patient to jump on board until the preventative model takes hold. So we need to diagnose and discuss blepharitis at the first sign of any lid inflammation, and that will plant the seed. Not only do signs and symptoms compound and increase, but so do costs. It is definitely more costly to treat a patient at late or end stage than early. There's a much different price point between a single BlephX treatment, or maybe 2 BlephX treatments in a year, than when we're treating patients for meibomitis, in which we're going to have to incorporate BlephX and LipiFlow. You know, can easily jump from 200 all the way to 1,000. My patients don't want to pay for anything. Does insurance cover BlephX? No, it does not, and I say do not apologize. Inform, do not apologize. Insurance and medical treatment are not on the same timeline or trajectory. Mammograms were not covered by insurance for almost 30 years. Does that mean that for 3 decades they weren't medically necessary? Or does that mean that insurance and medical treatment were not on the same timeline? Restasis is Allergan's second best-selling drug after Botox, with global sales last year of 1.5 billion. And this bullet point is telling in 2 ways. The first way is 1.5 billion for something that is covered by insurance but still kind of expensive for patients. Well, they're obviously paying. You don't get to 1.5 billion if patients aren't giving out money for it. Additionally, the #1 best-selling drug for Allergan is Botox, and more often than not, that is a cosmetic procedure. Patients will pay for things that they want, so we have to educate them to the point that they want to get this procedure done. Insurance does not dictate what is medically necessary. You as the doctor do. And that's something that we need to shy away from. We do not need to have such a crutch of relying on medical insurance. We just need to educate the patients.
Does this sound like you? Sweaty palms, high anxiety, deathly afraid to go to the dentist? Have you postponed your dental treatment due to fear? If so, we have a solution for you. We're able to help you complete dental treatment that you need, want, and deserve. Sedation dentistry allows our patients to relax and have dental treatment completed comfortably.
Okay, and I include this slide in here because of sedation dentistry. It's not covered by dental insurance. Patients will pay anywhere from $150 to $200 just for the sedation itself. Patients understand the necessity of deep cleaning, They're just terrified to get it done. So they're willing to pay out of pocket for something that they understand, even though they hate to get it done. So that should really resonate, that the dental model is successful in educating patients. What is okay to pay? And before I click on the next bullet point, I know that a large majority of you guys are already Blepharitis providers. You might already have your price point set, and that's absolutely fine. If you're successful in your model, then so be it. Don't let me change it. There are quite a few of you out there that aren't sure about your pricing. So what I say to do is look at the dental model once again. Dental patients report paying about 80 to 175 for a routine cleaning performed by a dental hygienist, and that's important because we're talking about a lid hygienist in your model, so a technician, average of 127, and anywhere from 114 to 320 for a complete teeth cleaning appointment that typically involves dental x-rays and an exam by a dentist. That's an average of about $200. So take into consideration the services that you're offering and make sure that you're not overpricing. We don't want to rely so heavily on the dental model with the explanation of the disease process and what we're doing, and then in the bottom of the ninth, strike out because we are overpricing our procedure. So make sure that we're being acceptable in what we're pricing it at. Dentists have done the research for patient private pay threshold, utilize their work. It is obviously successful. Just to give you a little bit of a story, last Monday, I got a thorough cleaning by my dentist's office, x-rays and a cleaning done by a dental hygienist. And at the end, I walked right up to reception to check out. They said, Chris, it's going to be $155. And I handed them my debit card and paid without even further discussion. And in that moment, it really resonated. I mean, it was a teaching moment because they have done such a great job, and I'm such familiar with the model, that 155 for what I received wasn't that bad. So take that into account when structuring this in your office. Standard of care right now are lid scrubs. And once again, I said earlier, patients don't do their lid scrubs. My patients are the worst. They don't do anything I tell them to. Well, I can't necessarily fault them with lid scrubs because if we look at the instructions, they all say eyes should be closed. So if we revert back to the education of dry eye decoded, we know that the biofilm or plaque covers the anterior and posterior sections. How can we expect at-home lid hygiene to be effective when it is designed for external anterior? If this was translated over to the dental model and I was your dentist and I sent you home, I'm not going to do anything in office, but I want you to go home and brush your teeth to stop this plaque and tartar accumulation. Brush your teeth, but only focus on the front. You're going to get a plaque and tartar accumulation on the back, which in our case is going to affect the meibomian glands. Once again, becomes more problematic in terms of signs and symptoms and more costly to treat for the patient. We need to do something definitive in office. And if you have Blepharitis currently, you have the ability to do that. It's just educating the patient so that they understand this is hygiene and cleaning they cannot do themselves with lid scrubs. Beware the biofilm. So I'm going to do a lot of correlation with these next couple slides in terms of, once again, the oral model. Biofilm formation or orthodontic patients is governed by similar mechanisms as common in the oral cavity. However, orthodontic appliance is hampered, don't worry about that so much, but we need to look at provide numerous additional surfaces which properties align in the oral cavity to which bacteria can adhere and form a biofilm. Biofilm formation will lead to gingivitis. So in terms of orthodontists, we know that by putting this foreign object inside of their mouth, it is going to adhere more biofilms and it's going to exacerbate their signs and symptoms or expedite their signs and symptoms of gingivitis. Once again, correlating to what we do, Staph aureus biofilm on the surface of a medical device is a common concern in healthcare, generally among contact lens wearers in particular. We need to take responsibility for our contact lens patients. This is one of the huge reasons we are seeing blepharitis, dry eye and blepharitis syndrome in younger patients. We're putting a foreign object in there and expediting and exacerbating their biofilm. Once again, reverting back to the dentistry model, they are taking responsibility for this aesthetic procedure. We need to do the same thing with contact lenses. Beware the biofilm in terms of eyelash treatments. With the rise of eyelash treatments also comes an increase in emergency eyelid problems. Blepharitis, a chronic inflammatory disorder of the eyelids, is a common problem associated with eyelash treatments due to bacterial overgrowth on the eyelashes. We need to take responsibility for these lash extension patients. Any of the ones that we see that have eyelashes and I'm not necessarily talking about the strips, I'm talking about the individuals that stay in for a long period of time. We need to take responsibility for them, educate these patients that they need to get it done in between their fills. Take it a step further, reach out to your local lashers and estheticians, educate them. They will be absolutely on board to educate their patients about receiving a BlephX treatment, an exfoliation of the lid margin, because what is job security for an esthetician or a lasher specifically? Lashes. And if we allow blepharitis, and especially the folliculitis aspect of it, to take over and destroy these lash follicles, well, they're not going to have patients for very long, are they? So we need to help them help their patients, and we need to help our patients ourselves. Data suggests that cataract surgeons should have an eye index of suspicion about dry eye disease and blepharitis and take steps to help identify and treat these conditions prior to taking preoperative measurements for cataract surgery. Take responsibility for your cataract and premium IOL patients. I know a lot of surgeons that anytime they fit a patient in a premium IOL, it automatically comes with a BlephX and a LipiFlow or similar treatment if they have that as well. They want to mitigate tear film instability so they don't put this patient in a premium IOL and have a negative outcome at the end. Because if you're charging, $1,500 to $3,000 for a premium IOL, and after the procedure they come out and they still can't see, you can't look at them and say, well, the thing about it is you've got three components to your tear film. You've got the mucus layer, you've got the lipid layer, and the water layer, and you're deficient on the lipid layer. And then try to upsell them, $1,000 for a BlephX and a LipiFlow. You've already lost their confidence and essentially lost their future business by not taking care of this disease process beforehand. Beware the malpractice. And I'll be honest, I have not found a single case thus far of malpractice with a doctor in terms of dry eye and blepharitis syndrome. That being said, when we look at the definition of negligence and malpractice, all a patient must do is show the delay in diagnosis and or treatment. So we know that we're diagnosing too late. So right there's a delay in diagnosis. Delay in treatment. If we're sending a patient home on lid scrubs, on things that we know are not going to be effective, that the only thing that they're going to do is slow down the signs and symptoms, well, that's a delay in treatment as well. We need to address it as soon as we see it, and if possible, treat it as soon as we diagnose it. All a patient has to do is find a reasonably competent and skilled physician who would have acted differently under similar circumstances. From my experience in dealing with ODs and MDs across the board, I've got very progressive doctors that are offering BlephX, LipiFlow, nutraceuticals, all these different dry eye situated treatments. And then I'll run into a doctor that is still prescribing baby shampoo. Well, we're talking about night and day in a standard of care there. And in terms of, the definition of what should be the standard, well, whatever best serves the patient. So we need to make sure that we are offering the best standard of care for a patient. We need to take responsibility. More importantly, we need to take action. The goal of preventative care is to help you safeguard against health problems in the first place and to catch illnesses in the early stages of development for easier treatment. Preventative care is also the most basic kind of health care you should receive on a consistent basis. It's the foundation of the tower. I can't stress this enough. You guys, they have done such a great job in the dental model. We are compliant with it, and we have seen just tremendous success in the regression of really horrible oral disease. We need to do the same thing in the ocular world. The road to biofilm. Patients need treatment as soon as they're old enough to drive a car. If the biofilm begins shortly after birth, then we know that, roughly a decade to a decade and a half after they're born, the accumulation really starts to take hold. Needs to be earlier if they're in contacts. As soon as you put a patient in contact, as we learned from that orthodontic model, We need to take responsibility and educate the patient properly. They already have an established biofilm, and the earlier preventative treatment is, I'm sorry, I worded that wrong. An earlier preventative treatment is easier than reactive. And that's what we're doing across the board right now. Even dry eye specialists, by the time you're seeing a patient, they're so advanced in their disease process that it's really hard to get a hold of. We need to do better by really kicking off this preventative initiative. An ounce of prevention is worth a pound of cure. Ben Franklin said that, and I really think that we need to take that to heart. You guys, that concludes the slide deck aspect. Pardon me. Let me see if I can start answering some of these questions. Do we have questions? No questions yet. You guys, I didn't do that good of a job. If anyone has questions, feel free to find that icon and pop in there, and I can start answering those to the best of my ability. Okay, I missed the slide about doing BlephX on the lash extensions. Okay, let me emphasize on that. Lash extensions, we should do those in between fills. I recently did it on one of my trainers that really wanted to get it done, and she had lash extensions. We flew those everywhere. The surfactant-based solution is going to deteriorate the glue that's used to adhere the lashes on there. So we need to make sure that we do this treatment in between. These lash extensions, just like contact lenses, they're foreign objects which kind of give the biofilm another source to spread onto. So if we're not getting these deep cleanings in between, we're only allowing the biofilm to advance. And Dr. Jake, hello to you as well. You guys, do we have any further questions? Oh, yeah. Oh, gosh. Sorry, I scrolled down. Let me see. Please show the ounce of prevention. I can send that to you. Let me get back there for you, Dr. Kaplan. Whoops, nope, that's not what I wanted. Let me get back there. And Dr. Kaplan, if you want me to turn that into a picture for you, I'd be more than happy to, okay? Okay, let me see, let me go down. Let me see. Success rate of BlephX since inception. That is a very subjective question. It just depends on what we're looking at. If we're and what else we're treating. If we're talking about strictly a meibomitis or a lacrimal laminitis case and we're just using BlephX, well, it's not going to be nearly as successful. We need to do something to evacuate those glands. We need to perhaps be using some sort of pharmaceutical to go after the biofilm that's on the lacrimal gland. We need to form a blockade to get a hold of the disease process. So success rate, and if you will do me a favor, and Doctor, I'm going to butcher your last name. I'm so sorry, Okudawa. I would be more than happy to send you some different studies that have been conducted. I think that'll be the best way to answer that. So if you could email me at chris@blephx.com, I'll send you all the published studies that we have on it. Dr. Solani, what cleanser are we recommending? Brand name, that's a hard thing to do. In the starter kits, we send out Lid Hygienics because it's hypoallergenic and has radish root preservative. That's a recommendation. And then for a mitricide or a Demodex treatment, we are sending out Blepharitis because it has obviously tea tree oil and coconut oil. That being said, our big thing is it has to be a surfactant-based solution to break down the biofilm. So there are a lot of great products out there. I know OcuSoft has quite a few, so it's really up to you on what you want to use in terms of the product, as long as it's surfactant base. Let me see. Medical consents. And we do recommend a consent form, and that kind of plays hand in hand with the walk the patient to yes presentation, which I can send that to you as well. Medical consents make everything feel like a medical procedure, which BlephX absolutely is. So if we set everything up to the best of our ability, from using proper PPE, gloves, face mask, to medical consents and ABN form if necessary, all these things make the procedure feel more formal. Avenova or Zocular. So Zocular I'm not absolutely familiar with, and I don't know if you're talking about the solution or Zest itself. In terms of Avenova, with fitting in this dentistry model, Avenova is like Listerine. So if we're using it at home care, then yeah, do your lid scrubs if you want, or use Avenova to keep these bacterial densities low. In terms of the procedure itself, I don't recommend doing it with Blepharitis just for the fact that you need that surfactant. And I don't think we've done any studies on if Avenova would break down the surgical glue. So for safety's sake, surfactant during the procedure, Avenova like Listerine at home. Yes, lash extensions, how can the estheticians benefit by us providing this service? Well, I mean, you're just essentially just like a referral sort of program. You're sending patients to them, and anybody that comes into your office asks what you guys can do. If they're not wanting to do Restasis, then you can send patients their way. But essentially, it's a matter of you scratching their back by taking care of their patients, and them scratching yours by sending patients to you. OxySoft foam, yes, Dr. Solani, absolutely. The surfactant-based foam. Lid cleaning solution we recommend with Blepharitis, we just covered that. So a good surfactant-based solution. A product called Lid Hygienics is something that comes with our starter kits. Blepharitis is the mitricide surfactant-based foam that we send out with our starter kits. Dr. Hayden in Indiana, what is the best practice for early post-Blepharitis treatment? Do you use steroids, antibiotic steroid, other instructions? It really just depends on what disease process we're getting. If we're getting them at folliculitis, where it hasn't gotten to the meibomian gland involvement, then pharmaceuticals might not even be necessary. It's just a matter of, at this point, it's hygiene. If we do have meibomian gland involvement, we definitely need to evacuate the disease product. So something like LipiFlow or something in office. Once again, Blepharitis needs to be used. We need to get rid of that surface biofilm. The reason that Doxy is not successful long-term is because Doxy cannot penetrate the biofilm. So if we remove that biofilm and we send them home with a little bit of an antibiotic or a combo drop, then we're able to get a hold of the process a little bit better. So if they're a more advanced case, you might have to strip down that biofilm, evacuate the meibomian glands, and then send them home with a antibiotic or a combo drop. Yeah, Dr. Kaplan just got there. Yes, I'll absolutely send you that. Do we have pamphlets and patient education materials that we can hand it out? Yes, absolutely. We have on our website a provider portal where if you log in there and the password I believe is Demodex, but we'll be sending out a follow-up with that portal as well. It has all sorts of pamphlet, printable patient education materials. And Dr. Solani, you're absolutely welcome. It was absolutely my pleasure. I can't wait to see your segment on the doctors, and congratulations to you on that as well. Consent form, yes, Dr. Rajiv, if you could do me a favor, email me at chris@blepharitis.com. I would be more than happy to send that consent form. But just because I'm going to have a lot of questions here, if you could take the time to send that to me, and I'll return with that consent form. As a matter of fact, we will be at the OSDI Symposium Twin Cities. I myself will be there. I typically don't go to anything but the major trade shows, but I will be at OSDI in Twin Cities along with our national sales director. How long do you have to wait after the procedure before fitting with contact lenses? It's a good question. And let me revert back to that on what you're doing. If you're doing it same day, then I always tell a patient whenever they're comfortable, after we irrigate, and the patient has become comfortable, then they can put their contact lenses back in. Now, if we are scheduling out, I like to tell patients to come into the office with no makeup, so we don't have to remove it, no lash extensions, so we don't have to tell them to come back a different day, and just to wear their glasses, just because it's a little bit easier. I mean, they're without makeup anyway, might as well toss on the glasses. But to answer your question directly, as soon as they're comfortable, they can put their contact lenses back in. Any lid abnormalities you would not do it on? I mean, if they have some sort of open festering wound that kind of takes priority on top of their dry eye blepharitis syndromes, I would wait till I have that under control. I have seen offices do this with styes and chalazions intact, so that's not something you necessarily have to avoid. But if there's anything that you feel is more important at the time of getting a hold of, then I would do that. Blefex, Avenova, Hypochlor from Ocusoft, how are they different and which one do you use for your eyes? Well, Blefex is an in-office procedure. Avenova and Hypochlor use hypochlorous acid, which is a good, it simulates, I don't remember the exact compound, but I've always been told, simulates white blood cells going after bacteria. So Blefex is an in-office treatment. Avenova and Hypochlor should be used at home. But when equating to that dentistry model, once again, Blepharitis is like going in for that deep cleaning, and Avenova and Hypochlor are like going home and using Listerine. After each procedure, we have to prescribe a combo drop? No. As a matter of fact, I definitely do more Blepharitis procedures than anyone in the world, and oftentimes it's not in a clinical setting so much as a training setting. And what I do is I make sure I irrigate very, very well. That's paramount. Irrigate very well. Explain to the patients they might have a little bit of a foreign body sensation for up to 3 hours. I might even sometimes say 24 hours post-procedure. And generally that sensation of discomfort will go away, or by discomfort, I mean foreign body sensation. I would only prescribe a combo drop if they have a very advanced stage of dry eye blepharitis and you feel that you need that added oomph or assistance. Some patients' eyes do feel drier at the end of the day, so I have them use artificial tears such as Refresh every couple of hours, a couple times a day. Any other suggestions? My biggest suggestion, and I know that we discussed this yesterday, Dr. Yaldo, is it's more of the cosmetic side. Use Lumify, you guys. At the end of the procedure, use Lumify. We as patients, or as humans rather, we can feel bad. So if I have that foreign body sensation, you know, I can deal with it, but I can't look bad. So if I use a little bit of Lumify at the end of the procedure, I can get rid of that redness that's more often than not caused by proparacaine. If I can get rid of that redness, that patient is going to have Photoshop white eyes, and they're going to feel great. And they're going to be able to ignore a little bit of that foreign body sensation. But if you want to use a little bit of an artificial tear just to kind of get them through that, then that's absolutely welcome. And yeah, I'm sorry, Dr. Yaldo, our secret's out of the bag on that one, but definitely, you know, you can use a combo drop post-care, a little bit of artificial tear post-care, and Lumify post-care. All right, I still have 45 people in the room, or 40. Do we have any additional questions, you guys? I'd love to keep this going. I'd love to help you guys lead the charge to make this a preventative model. It's my dream. My kids just got their teeth cleaned 2 weeks ago, and there were 4 teeth cleaning chairs in a row, and there was a dental hygienist at each chair doing the preventative cleaning, and then the dentist came through and was able to check on the oral cavity for care. So it's my dream to see that kind of model taking place, where even after, you know, what am I saying? After their pretest area, that they might even be going to get cleaning, or after their comprehensive exam, they're getting cleaning done each and every time they come in. All right, guys. Well, if we don't have any questions, once again, my contact information is chris@blefx.com. If you guys would do me a favor, and I thank you so much for giving me your Thursday evening, if you guys would go ahead and follow us on Blefx, Lord have mercy, it's a night, on Instagram at Blefx. Very simple. That's how you find our page. And also follow us on Facebook at Blefx. We share a lot of this content on there, as well as, you know, some funny memes that you can share on your page as well. I would be more than happy to keep the content coming, so you guys can share it and educate your patients as well. Educational videos, properly performing Blefx online. Yes, if you go to our YouTube channel, once again, that's the Dry Eye channel. There's content there. If you utilize the portal that we'll be sending out, there's a video there as well. And I will send to all of the attendees here a recording of this video tonight, a recording of a Walk the Patient to Yes, the private pay procedure, a recording of Dry Eye Decoded, and a video on how to properly do a Blefx treatment. I would be more than happy to assist you with that. And if anybody attending does not have Blefx, you're more than welcome to reach out to me and I can get you pricing information. We actually just came off of a trade show, so if you're looking to implement rather soon, sooner rather than later, I should say, I can get that over to you. But it looks like the questions have stopped streaming in. So you guys have my contact information. Feel free to reach out to me at any time. And I'm even okay with you giving me a text message. Completely okay. But you can reach out to me. Facebook, Blephex is our handle. Instagram, Blephex is our handle. Chris at blephex.com, CHRIS at BLEPHEX.com, and my telephone number, direct line, is 270-791-8234. You're more than welcome to call or text. I will send these recordings to you guys, and I thank you so much for giving me part of your Thursday evening. Thank you so much, and have a great day.